Greetings, my name is Dr. Sajad Zalzala. People call me Dr. Z. Today we're going to be talking about the body composition and metabolic dysfunction module preview as part of the Optional Aging Academy. Today's topic is why fat distribution, muscle mass, and metabolic drift matter more than just weight. All right, before we begin, I'm going to talk a little bit about your guide for today. My name again is Dr. Z. I spent the last 2 decades focused on functional medicine and longevity. I'm the previous co-founder and chief medical officer of AgelessRx. It was one of the first telehealth platforms dedicated to longevity. I've worked with multiple telehealth companies and digital health companies working on diagnostics and digital health over the last several years. I've also offered numerous papers. The framework that you're going to see today, or the module preview today, is basically 20 years in the making, and it reflects my clinical pattern recognition, my clinical intuition, my clinical experience, and everything I've learned in the last 20 years in longevity. And it's not just theory alone. So what we're going to cover today, several different topics. First of all, why body composition is more than just weight. We'll talk about how fat and muscle distribution quality can alter metabolic risk years before we see any changes with the lab work. And then we'll also talk about visceral fat insulin resistance, how VAT, or visceral adipose tissue, drives dysfunction, metabolic dysfunction, how to measure it, how to reduce it. And then we'll also talk about the 4-compartment model, visceral fat, subcutaneous fat, skeletal muscle, and bone density, and then why each of these matter. And we'll talk about the different patterns we see when it comes to early metabolic drift and dysfunction. Before we begin, I was tempted to call this module weight management or weight loss, but it's a lot more than just weight. It's a lot more than just about how much your scale tells you that you weigh. There's so much more to it. So that's why I decided to call it the body composition and metabolic dysfunction. Because it's the metabolic dysfunction, more than your BMI, more than how many pounds it says the scale are, how many molecules you have in your body and mass you have in your body. It goes much beyond that. So I didn't want to minimize it by calling it a weight loss module. And not to minimize weight loss, but focusing just on weight loss is going to do this module a big disservice. Now, it's going to be a central theme of this module, but I want to make it clear that it's not the only part. So it's regardless of whether somebody is considered to be normal weight, underweight, overweight. That's part of the reason why I didn't want this module to be just about weight. It's about body composition as a whole and metabolic function or dysfunction. So visceral fat is it's a deep abdominal fat in between the organs. Many years ago, we used to think it was just cushioning for the organs, but then we realized it was an actual organ itself. You're supposed to have a little bit of it. It still functions as a cushion, but the less you have, the better. And the more you have, it gives off all sorts of signaling. We'll talk a little bit about it in the module preview, but then we'll expand upon it even further in the full course module. Suffice it to say, for visceral fat, you need a little bit, but less is better. And there's really no reliable way to measure it other than through something like a DEXA scan or maybe even an MRI. And we'll talk about some of those tools today, but we'll expand on it greatly in the module itself. And then there's subcutaneous fat. That's what everybody thinks about. That's like how much fat you have on your arm or your belly. That's they write it directly under the skin. Again, originally we thought it was just storage, benign storage, but then we realized that it was much more than just benign storage. And then there's muscle mass. It has garnered a lot of interest recently from a lot of people in the longevity space. This idea of sarcopenia, or muscle wasting as you get older. And then the 4th compartment is bone density. We'll talk a little bit about that today, but that's actually going to be reserved for another module. So we're not going to expand too much on it today. We're going to talk a little bit about visceral fat because it's very underappreciated, very under-discussed. A lot of people talk about subcutaneous fat, like how much fat you have under your skin, or how much belly fat you have, external belly fat. Visceral fat is almost like the internal belly fat. You can't see it, you can't measure it, other than through some of the advanced measuring technique. You can estimate it based on various different things, but there's going to be plenty of people out there where these measurements are not reliable. You really do need direct measurement. We can talk a little bit more about that today, but we go into detail in the full module. Part of the reasons why it's problematic because it produces or encourages high free fatty acid output. It can release free fatty acids. It can overload the liver and muscle and then lead to insulin resistance. It's also considered to be a cytokine factory. Cytokines are the molecules that are given off by various different sources in response to inflammation or as a causative agent of inflammation. In the case of adipose tissue, we think it's a two-way street. It increases in response to inflammation, but it also itself generates inflammation through cytokines. And cytokines is just a general term for these inflammatory molecules. And then the The inflammation and then the glucose deregulation also comes along with HOMA-IR. HOMA-IR is a measurement of insulin resistance. And this is actually central or key to the metabolic dysfunction. And then there are hidden dangers. I own a DEXA scan as one of the businesses that I own at DEXAFit Detroit. And DEXAFit is a facility you can use to do a DEXA body composition scan and actually check to see what your visceral fat is. And I've been surprised a number of times I've seen people who think that they're normal weight or healthy weight, and yet they have quite a bit of visceral adipose tissue. So again, this is one of those things where you can estimate it using various different tools, but you really do need to measure it. And it's what's considered one of those hidden dangers because it's internal. There's no way you can measure it externally without one of these tools. Just reiterating the 4 body composition model, you got the visceral adipose tissue, you got the subcutaneous fat, which is a storage. It is a storage vehicle, but it's not just benign. And then you've got skeletal muscle mass and the bone density. Here's a visual in terms of high functioning resilience. On the top, on one side you have structural integrity, on the other side you have metabolic risk, and on the bottom you have low function vulnerability. And you see kind of each of these quadrants. Skeletal mass, skeletal muscle is important for insulin sensitivity and loss of it. Sarcopenia, it's called in the medical field, leads to frailty, insulin resistance. You can't dispose of glucose like you used to. The visceral fat we've already talked about extensively. Subcutaneous, again, you need some subcutaneous fat, especially women. But so it's just like anything, you'll see the central theme in longevity is balance and optimization. You don't want 0% body fat, especially women, because then they start to have all sorts of hormonal problems. But you don't want too much either, because it can also give off cytokines and inflammatory markers and whatnot. And of course, bone density, very commonly thought about for women over the age of 60, but men can also get low bone density. And I can't tell you the number of young people I've seen who have unexpectedly low bone density. So that's why it's you can't just assume or guess, or you don't want to, God forbid, wait until you get a fracture and then go out and measure. It's very important to be proactive. And that's why I built these modules to help people figure out how to assess properly without overdoing it. Metabolic dysfunction is a continuum or continuity spectrum. On the extreme, you have people who have like really poorly controlled diabetes. They have an A1C of 15%, where normal is around 5. But you don't wake up one day diabetic. It's a continuum. You go from normal glucose, normal resistance, normal HOMA-IR, and then just over the years it inches up. Sometimes you can get some life events, stressors, certain medications like steroids can really cause a temporary, sleep disturbance can cause a temporary jump in this metabolic insulin resistance, this metabolic shift. And then depending on how resilient somebody is, they can come back down to normal. Of course, year after year, having more and more of those events, your body becomes less and less resilient, and eventually you shift over. And it just so happens that we set the cutoff for being diabetic at an A1C of, when you go from 6.4 to 6.5, we call you diabetic. But of course, that doesn't happen overnight. It's usually something that's years in the processing. And then the metabolic dysfunction has various different costs and consequences, such as brain fog, post-meal crashes. The insulin resistant makes it harder to lose weight, sometimes hard to gain muscle. And then, as I mentioned before, that can cause inflammation, which then can lead to visceral adipose tissue growth. And then that kind of feeds the cycle, and you end up with a vicious cycle that you need to figure out how to break. And then that all can feed potentially back into the sex hormone system. And you'll get, women will suffer from things like abnormal periods, what's called polycystic ovarian syndrome. Men will have a decrease of their testosterone levels and have other metabolic issues as well, hormonal issues that go along with it. So you can see that this metabolic dysfunction cuts across a lot of different markers of aging, drivers of aging, and concerns of aging. All right, so how do I identify the metabolic bottleneck? It's not just about fuel, it's not just about sugar. It's about regulation. You want everything in balance. You don't want too much insulin, you don't want too little. You want to find that optimal level, the balance. Again, inflammation, you don't want zero inflammation, but you don't want too much either. And then fat partitioning, again, you don't want too much fat, you don't want too little either. So the bottlenecks can generally be divided into insulin signal disruption, like we talked about. Insulin is like the key, and most cells have what's called the GLUT reactors, GLUT receptors. And insulin is like a key, and those are like a door. Over time, the key becomes less effective, or the lock to a door. The lock becomes less sensitive to the keys. So that's why you need more keys. And then it's a brute force at some point. And then there's misrouting, where fat gets stored in different parts of the body. Sometimes where fat gets stored is a clue, and we talked about the last place you want the fat is in between your organs, the visceral part of it. And then you end up, the metabolic dysfunction can also lead to mitochondrial slowdown and dysfunction. You get all sorts of problems with the mitochondria. It doesn't convert fuel into ATP like it used to, and you get all sorts of problems with that. And then you also end up with glycemic overshoot or instability, where you get spike crash. And that can be very detrimental. And people can handle that for a short while, but after a while, it becomes really problematic. And this also helps explain why you can have two people eat the same exact thing at the same exact time, but they react differently to it. And that's why, this is a different discussion for a different day, but that's why there's no universally optimal diet. And we'll talk a little bit more about this in one of the other modules, specifically on nutrition. All right, so how do we assess? Just like almost all of our modules, you'll see that there's a subjective assessment and an objective. So let's talk about the 10-question metabolic self-assessment. So we try to screen for these things using a scored system that I've developed based on my clinical experience. So we ask questions about glycemic fluctuation, fat distribution signals, clues to help determine muscle reserves, and metabolic resilience, especially under stress. So I've developed these self-assessments you'll see in the various different modules to help pick up clues, and we can talk about why that's very important. Again, the whole framework of these modules is to understand, assess, and then intervene, and then of course reassess. You want to make sure there are variety different ways or variety different reasons why you might be on the right track, you may not be on the right track. So that's why reassessment is very important. All right, so what do we actually measure? Again, we'll go into detail. This is a preview, so I'm not going to go too much in detail, but I've already mentioned the DEXA scan. This looks at the body composition, gives you multiple readouts. I've mentioned the term HOMA-IR. That's a measurement. You basically take glucose and insulin. There's an equation for that. It's really easy to calculate. Sometimes we'll look at the CGM data and look for the patterns that we talked about, the spike and crash, what spikes your sugar. And then sometimes we'll look at fasting insulin, which kind of plays into the HOMA-IR. And there are other advanced measurement tools, but again, these are some of the tools that we looked at from the objective perspective. When I say objective, these are like things you can measure, biomarkers. It's not always blood biomarkers. DEXA scan is a test. So when I say biomarkers, it can be blood biomarkers. It could be other ways that you measure things. Sometimes we resort to wearables like a CGM, for example. All right, so why do both? Why do subjective versus objective? So the subjective is dynamic, situational. It could be early indicator. Anybody can do a subjective analysis or a subjective assessment. It's basically a set of questions to help identify where you currently are and help lead you down the right path of where you need to be or what you need to do in order to get where you need to be. But of course, that by itself is not always complete. There are some situations where it is, but for most modules, you'll see there's a subjective and an objective assessment. And it's really important to try to do both if you can. Everybody can do the subjective. It's just a set of 10 questions typically. Sometimes getting the data for the objective is a little harder, but I highly encourage it. And the full course will tell you exactly what to do with that information, how that's scored, and then what you can do about it. So we're going to be able to preview here today. A little taste of what's to come in the full module. So again, I like the subjective because it's accessible. That's been my mantra since day one. What good is the best medicine in the world if it's not accessible? If you have to go to some academic university lab out in the middle of nowhere and pay tens of thousands of dollars for it, nobody's going to do it. Maybe research trials will do it. So that's why I focused all of the assessments on trying to be as practical and as accessible as possible. And that's why I really like the subjective, although there are some limitations to it. Again, why we combine it, the subjective, like I said, gets you started, gives you some clues to patterns. The objective data confirms it or locks it in. Once in a while, you get conflicting data, and we'll talk a little bit more about what to do in those cases in the full module. And then just an example, a normal BMI person can have a high HOMA-IR. You want a HOMA-IR, the lower the better. So less than 2, according to some people, is good. Less than 1, according to some people, is good. But let's say somebody is normal BMI and said, "Oh, I'm metabolically healthy just based on my BMI." That could be a false sense of security. And when you actually measure, you could see that they have an elevated HOMA-IR. And then you could also look at their subjective measurements and see that they might have sugar crashes, spikes, and cravings and whatnot. So it's not just because some of your measurements are okay. Some of the standard measurements like BMI, body mass index, by the way. In case I didn't. At this point, everybody knows what BMI is. Body mass index, it's a formula where it takes your height and your weight and then comes up with this number. You can read a little bit more about it. It's a very commonly used measurement in medicine. But don't assume that just because you're in the normal range that everything's hunky-dory. It could be. I think most people are. If their BMI is normal, then it's a pretty good approximation. But you'll see in these courses over and over again, you don't want to guess. You want to assess. Don't guess, assess. All right, so the assessments lead us to these archetypes. Now, archetypes they're my way. These are archetypes that I've identified, and these are ways for me to help my students comprehend the patterns that I've seen clinically. And then from those patterns, where to go to next. Like what's the best interventions or set of interventions that you need. So the assessments lead to the archetypes, which can lead to where you get the biggest bang for your buck when it comes to intervention. That's where a lot of people fail. Is they might do a bunch of blood work and then they're overwhelmed with the results, for example. They have no idea where to start. Or it's like throwing spaghetti against the wall and they just hope that a few of the strands of spaghetti stick. We might get somewhere with that, but a lot of people don't. They get discouraged. They're like, oh, why isn't this working? Because you have to identify the pattern. And the pattern helps us, these patterns or these archetypes help us identify what's the underlying cause. Then you can more deliberately target the underlying causes. So what are the four metabolic archetypes? We have the visceral dominant type, the sarcopenic drift type, the glycemic volatility type, and the mixed breakdown type. So let's go through these one at a time. Archetype number one, the visceral dominant pattern. So this is where somebody has excess visceral fat, and it's usually an early warning sign that they're headed towards metabolic issues if they're not already there. The key features here, people get central fat gain, especially around the abdomen. Sometimes they'll come up as like a beer belly, or there's a doctor out there who calls it a grain belly. And you'll see maybe their fasting glucose is normal, maybe a little on the high side, but not too bad, not enough to do anything about from a conventional perspective. But their insulin resistance is starting to really suffer. They can have sluggish energy, especially in the morning. They just can't lose weight. And then their labs, year after year, you get a little bit of creep, a little bit of creep, a little bit of creep. And again, a lot of these patients or people aren't yet diabetic, but they're on that pathway to it. And the primary focus here is get them back into the insulin sensitized space. And then you want to target the visceral adipose tissue through inflammatory and insulin sensitivity. All right, archetype number two is a sarcopenic drift pattern. This is where, for whatever reason, somebody's not able to maintain, or maybe they just never had any muscle to begin with. And this could be for a variety of different reasons. Maybe somebody who's athletic when they were younger, and then life gets in the way and they kind of let it all go. Also, as popular or powerful the GLP-1 medications like semaglutide or Ozempic, if you're not careful, you can lose a lot of muscle mass with those. So there are a variety of different reasons why people end there, but regardless, the end point is that their weight may be normal, quote unquote normal. The BMI is normal, but they're in an uncomfortable position or a bad metabolic condition, suboptimal metabolic condition where they have too little muscle mass. And then you end up with just not able to lift as much as you used to, not being as robust in terms of physical activity, much harder to maintain weight loss, much harder to lose weight, much harder to maintain it. And then over time, the weight goes up and they're like, oh, why am I gaining so much weight? I used to be normal. Again, a lot of it has to do with not having enough muscle mass. And here we target the muscle interventions, rebalancing the body composition. So some people may gain weight, which is fine as long as it's the right type of weight. Some people may not. You could kind of shift the muscle to fat ratio. And again, this is particularly important in this day and age where so many people are on the GLP-1 class of medications. All right, archetype number three, the glycemic volatility pattern. This is the spike crash that I was telling you about. They'll get swings in their blood sugar. And this usually leads to low metabolic resilience, especially during times of stress. When they do fasting blood work, most of the time their markers look normal. Their blood sugar looks normal. The A1C looks fairly normal. But if you dig a little bit deeper, you ask more questions, maybe you put them on a CGM sensor, you'll see that spike and crash that we're talking about. And people tend to get mood swings. This is where the term hangry comes from, where somebody is hungry and angry. Because usually it's after somebody's had a high carbohydrate meal, and then their insulin kicks in and they get a crash. And that crash is where they start getting hangry. So they feel like they're on an energy roller coaster. And of course, it's a self-feeding cycle because when they get the crash, they go back for a high carb meal again, and then they get a spike and then a crash. And so they're on this vicious cycle that we need to break. And so that's what the primary focus is. And nutritional strategies to identify the spikes and then neutralize those spikes as much as possible, stabilize the blood sugar. There's a variety of different techniques we talk about, the interventions, therapies in the full module. All right, here's the mixed breakdown protocol. Basically, a little bit of everything from the other three. You can have high visceral fat, reduced blood sugar, basically the worst of all the worlds here. And unfortunately, a lot of Americans and people around the world fall into this category. And the key here is to identify it early and figure out which one to focus on first. It requires layered strategy. And again, we talk about in detail how to go about intervening. We'll talk about in a minute a little bit about some of the interventions, but we go into much more detail in the full course. All right, so where does BMI fit into this? I mentioned BMI. I even told you it was called body mass index. It's a starting point. For somebody who has a low BMI, it's rare, it seems like in this day and age, but they could have some metabolic issues. It could be a thyroid issue, for example. It could be an eating issue where they perceive that they're not at a healthy weight, so they reduce their calorie. And then the normal BMI. So BMI is defined, healthy BMI is thought to be between 19 and 22, 23. And once you get above 23, above 25, you start getting into overweight. And then once you get above 30 BMI, then you're considered to be obese. I don't really like that term, but that's the terminology used. And then there are different categories of obesity depending on how far up that ladder you go for BMI. BMI is a good starting point. It's not useless. It just doesn't tell the whole story. And it typically can be used to gauge the severity of the dysfunction. Like I said, if somebody's BMI is normal, I mean, there's a reasonable chance that their metabolic is normal. And it's unlikely that they have like really severely disturbed. Not impossible and not improbable, but unlikely, less likely. And so that's where BMI kind of fits in here. And you won't see me use BMI too much. Like I said, these other markers we talked about are much more precise. A lot of people, they read about body composition and they tend to gravitate towards generic metabolic advice. This tends not to work out very well for a lot of people. They might focus on one thing, like if they're going on a medication, just like a GLP-1, which helps them lose fat, but also can help you causes muscle loss as well. And everybody's a little bit different. And that's why I came up with the archetypes to help identify the patterns that people fit into to better target the interventions that they need. And that's where you get mismatched interventions. That's where you get a focus on the wrong outcome. They're focusing on the scale when the problem may not be on the scale itself, may not be mass. It may be these other markers we're talking about. All right. To go from archetype to strategy, again, we already talked about this a little bit, but just to reemphasize, if somebody has too much visceral fat, then we target that. That's what we target, that fat, where, the various different interventions to try target that and bring that down. Once you bring that down, a lot of other things get fixed. Sarcopenia, if somebody has low muscle mass, again, you target that. You protect the lean mass and you improve that lean mass. And like I said, a lot of other aspects of the metabolism get fixed. And likewise with the volatility and the mixed, there are very specific interventions we're going to talk about in the full module on how to fix these various different archetypes. And without knowing the archetype, it's hard to figure out what the underlying cause is. It's hard to target the interventions that are needed. All right, so what does it look like when somebody's done the assessment, identified their archetype, and then started on the path down towards intervention? What does it look like? There are 4 major things that'll happen. You'll end up with a lower baseline load. It requires less effort to stay within the normal zone. Because take glucose, for example. Your body works very hard to keep your glucose in a very narrow range. Once you start developing metabolic dysfunction, that ability to stay in that normal range gets strained and becomes harder and harder for the body to maintain that. But as you start intervening properly, then you'll see that it's much easier for your body to stay within that range. Improve partitioning. This means that the fat will be stored where it should be stored and will be distributed more evenly. Reduce glycemic excursions. You'll see a leveling of blood sugar rather than crashes or spikes. And then better recovery. And this kind of goes back to keeping your body in that range. All right, why does it matter to reassess? Why can't you just assess once and then move on? Because you want to make sure you're on the right track. Everybody's different. What works for one person with the exact same set of circumstances may not work for somebody else. So that's why it is trying to find the best solution for an individual student. And that's where reassessment comes. Are you on the right track? Do you need to look elsewhere? Are you following the right strategies? Are you doing what you're supposed to do? Or are you cheating too much? And it'll give you feedback on whether or not you've hit the nail on the head or you're off by a lot. If you hit the nail on the head, great. Continue what you're doing. Keep down that track. And if not, then you need to stop again. Say, okay, what am I doing wrong? Maybe you need to take an assessment again at that point. Measure those biomarkers again at that point, and then reconsider your strategy. It also is encouraging. If somebody's on the right strategy, they're on the right intervention, they're seeing their markers are moving, their assessment's getting better, it's very much a motivating factor as well. So let's jump into some cases. So here's a case of a male in his mid-40s, typically an active lifestyle, relatively clean diet, or at least he says that anyway. But he has midday energy crashes despite saying he gets enough sleep. And he's noticed a gradual increase in his belly fat over the last couple of years, and he just feels off. His labs are within normal limits, the standard labs anyway. He does the testing based on the biomarkers we talked about. His A1C is okay, not too bad. His glucose, fasting glucose is within normal limits. He's not diabetic or anything like that. But we do see an elevated insulin level. And he has an elevated waist circumference, and we didn't need a measuring tape to know that. He's already reported that. So in this case, he's the kind of the classic sign of visceral dominant drift with insulin resistance. And he's starting to develop metabolic inflexibility where he's just not tolerating glucose and carbs like he used to. So now that we've identified that, we can put him on targeted, or he can find the right targeted interventions to help him improve metabolic partitioning, reduce central inflammatory load, and stabilize blood sugar. So what does that look like after? We would expect, if we follow the right interventions here, more consistent energy with reduced or no crashes, reduction in waist size, reduction of that hangriness or that fog that goes along with the crashes and the inflammation, and then fewer cravings as well, like not reaching for that bagel every time he feels hangry. And then follow up, we'll see normalization and improvement, shift towards optimization of his biomarkers. So the key takeaway, again, pattern recognition, focused strategies, focusing on the visceral adipose tissue by measuring it properly, and then looking for the right interventions, and of course, reassessing. Let's move on to case 2. So this is a 52-year-old female. BMI is normal. You look at the BMI, it's a perfect BMI in the low to mid-20s. That's where you'd probably want most people to be. Active, but slow recovery, not taking a lot longer to recover than she used to. Even though she says she's the same weight on the scale, she feels like her clothes are tighter. And she can't lift as much as she used to. She's not as physically robust as she used to. And she gets some carb cravings and fatigue in the afternoon. Somebody like this would go out and get a DEXA scan, find that the lean muscle is quite a bit lower than we'd like. So this person has lost a lot of lean tissue along the way. Fasting glucose is typically normal in this type of case, but you might see insulin starting to drift up a little bit because muscle is a very powerful, building muscle is a very powerful way to sop up the sugar and therefore improve insulin resistance. And then even though the weight hasn't changed, the distribution, lower muscle levels, higher overall fat. And so if this person would have done DEXA scans before, you could see the change over time. All right, pattern identified. So this is a sarcopenic drift case. We talked about lower muscle, which slows down the metabolism. You don't have that storage buffer for the insulin and the glucose anymore. And so the key will be building that muscle back up again and then restoring. And that could lead sometimes to temporary weight gain. As you're building the muscle, you haven't necessarily started losing weight yet. But that's fine, again, as long as you know what to look for. Eventually, it'll stable back out again, and we would expect this type of person to go back to the baseline weight, but in better metabolic shape. All right, so what does it look like if this person found the right set of interventions, improved muscle mass, strong on the workout, less soreness, better recovery, clothes going back to fitting properly, and more metabolic resilience and fitness. Key takeaways for case number 2. Again, this is where weight and BMI can be misleading because she had a really good BMI. This is about composition and the consequences of a disturbed composition or suboptimal composition. So it needs to be a holistic focus, looking at the entire person, the entire metabolic picture. Here's a case number 3, 39-year-old male, BMI is 23, which is really good, recreational runner, has a high-performing job, but travels a lot. Blood tests are pretty normal. A1C is 5.2, glucose is normal, insulin is not bad, borderline high. If this person were to use CGM, you would see spike and crash and spike and crash. They get brain fog, especially about a half an hour to an hour after a meal, especially lunch. A lot of people like to eat sandwiches and bagels during lunch. And so they can get that brain fog, that hangry, they can't think straight. And sometimes they can cause anxiety or debility, other kind of mood issues, just not being able to perform properly. Sometimes the blood sugar will stabilize when they fast, but sometimes they fall into this trap of eating cleaner carbs. And sometimes they'll go into a high carb diet thinking that they need more carbs to stabilize their blood sugar. But that can actually backfire sometimes. Next slide. So the pattern here is the glycemic volatility pattern. We talked about this before, spike crash plus spike crash. The body is shifting away from being able to keep the sugar in the normal range. A lot of it has to do with stress. A lot of it has to do with just repeated stressors on the body from the carb overload that a lot of people tend to do themselves. And it's a mix. Next slide. So after we find the right interventions for this type of person, we go based on the CGM sensors, make sure we flatten out, keep the sugar as stable as possible. They don't have the mood swings anymore. They don't have the hangriness anymore, more stable throughout the day. Even things like sleep starts getting better. Better focus, better reduced food anxiety. They don't feel like anxious anymore. Next slide. Key takeaway here. Again, you want to look beyond just the regular blood work. You want to look at CGM sensor readings sometimes in these kind of cases, and you want to target the stabilization rather than just blanket somebody, you have a normal BMI, there's not much we can do for you sort of thing. All right, next slide. All right, so what actually changes when you target these archetypes, these bottlenecks, or these patterns that we see? So again, you end up with lower baseline strain, improved partitioning, greater metabolic flexibility, and more predictable responses. It's not all over the place, spike and crash and things like that. Your body can do a much better job of staying in the range that it needs to be, that's considered to be healthy and optimal. So what does that look like? Like we talked about in the cases, to reiterate, fewer swings, more stable sugar, improved overall body composition measurements, recovery is increased, and physical capacity is also increased. How do we track progress? We reassess. We look at the subjective assessment, we look at the biomarkers, we look to see, I teach students how to look for these various different things, and again, how to stay on the right track. Why this changes your aging trajectory? What does it have to do with aging? Metabolic dysfunction has a lot to do with aging. Visceral fat is very central to metabolic dysfunction. Muscle loss, again, a much bigger deal as you get older, especially people over the age of 50 and 60 really need to pay attention to their muscle loss. That can lead to frailty, loss of independence. Your cognition takes a big hit when your sugar spikes and crashes, and then insulin resistance cuts across so many different things. It's not even funny. All right, so now that you've seen what this module is about, what you'll find in the full module is the metabolic assessment framework. We'll talk in detail about these archetypes. If you've had a preview today, we'll talk in depth about the different interventions, and the logic behind the interventions, and how students can go about figuring out what interventions to start with, how to track, how to optimize, and then how this module fits in with the other drivers and the other concerns of aging, as well as the diseases of aging. So I try to explain how this fits into a larger web and framework that is aging. Just a quick note about bone density. Like I said, we didn't talk about it here, but it is important. But I put it into another module on strength and mobility, where we talk about some of the interventions there. It's not necessarily a driver of aging, it's more of a consequence of aging. Your bone is more like a reactivity rather than a driver. So that's why I didn't necessarily put it here. It does fall within body composition from a category perspective. Functionally, it actually falls more into a different module. So I didn't forget you bone density, just not today. So who's this module for? People who want to understand their body, why it's changing. It's not just for weight loss people. I mean, there's plenty of tools out there to lose weight. One of the goals is to lose weight on this module, but it's not the only goal. I emphasize this really early on in the module. This is for people who value data over dogma. If you're stuck to one type of diet or one type of exercise regime, this may not be for you. This may not be for people who are looking for quick fixes or just, give me a protocol to follow. That doesn't work that way. That's why I have this deliberate system of understanding, assessment, and intervening. And there's no shortcuts here. The only shortcut here is understanding the system, understanding your system, and helping you cut to the chase rather than beat around the bush and try different interventions that may or may not work for you. And of course, this is not people who are like super competitive. So it's not for like weightlifters or bodybuilders or people like that. This is more for everyday normal, quote unquote, normal people. The information could be very useful for people who do have competitive sports and things like that, but this module is not specifically for them. They require that kind of group of high performers. There are other courses and things like that out there. They tend to follow different rules than the rest of us. So how this fit into optional aging? I talked about how it cuts across things like mitochondria, hormone, immune regulation, cognitive function, resilience. All right, where this goes next, again, the full module. We talk deep and pattern recognitions, what the assessments are, how to take them, what they mean, the strategic intervention logic, and then how it integrates. All right, I hope you found this useful. Again, this is just a preview. You can either sign up for the framework overview webinar that I hold or you can jump right into the full module, or you can just follow us to keep updated on the latest and greatest with the Optional Aging Academy. Thank you very much.